job. Thank you, Katie. I'm Kristen Diehl, for anyone that doesn't know me. Actually, this is my 15th year as a full-time faculty member at MCC. So I was just telling Stacy this morning, I got to pick my prize from the catalog, the e-catalog. And
I'm Sara Rittersdorf. I am the full-time chemistry instructor, first year here. And Kristen and I actually met each other as fellow heart moms before I started working here.
Yeah. So actually the day I found out Scott was going to retire, before he announced it, I messaged her. And I said, hey, I know this is a goal. Keep your eye open. And she said, I already know. So I don't know how she already knew, but she already was fully aware. So it's awesome that those worlds collide. And I'm guessing probably Lisa may have suggested that, or your dad, that you should contact me. I don't know, just guessing.
Yeah.
So we're going to go through today, tell you about our stories with our children who have congenital heart defects. First, we'll start with just some general information and statistics about congenital heart disease and defects. And then we'll tell you each of our individual stories.
And then kind of what is to come and what the future holds for each of our children. And there are some hard slides. So there are probably going to be some tears. So there are Kleenex around the room, and we will probably tear up too. So
yes,
disclaimer.
Yes, I can already feel it in my voice. So.
Yeah. But at the same time, it's not necessarily a bad thing. It's part of the healing process, and just accepting that this is a reality.
So Sara reached out to me last semester and asked if I wanted to do this, and February is Congenital Heart Defects Awareness Month. So we're shooting for it was closer to Valentine's Day, but this worked out great with this events here. So thank you for giving us the opportunity to just tell you about congenital heart defects. And I hit the button, and there it goes.
So congenital heart defects, commonly, you're going to hear a lot of acronyms. The first one is CHD. That's the most. It's just the blanket statement for anything, really dealing with a heart defect. And it's just saying a heart defect in utero, during development, and it really is one of the most common birth defects out there. And about 1 out of every 100 babies have a heart defect of some sort.
So as you mentioned, a lot of them are caught in utero during that that 20-week ultrasound scan that they do, but not all of them. Actually, neither one of ours were caught in utero. So
they were caught not even at the hospital. You know how they do the heart scans? They weren't during the testing, the first right after the first 24 hours. Ours were caught. Yours was Kelly's was about 2 months, and Elliot was 10 days.
So about 25% of the children born with CHDs need surgery or other medical interventions to survive. Some don't. And then, when I posted an awareness this month, one of my husband's aunts commented, yes, my husband had a hole in his heart, never knew it. They kept telling the doctor something's not right, but it was never corrected. But he lived till he was older. But so.
And these can be as simple as, one of them is a bicuspid aortic valve, an aortic valve with 2 flaps instead of 3. Some people live their whole life. There was actually a cardiologist on, not his team, but that was known through his team that had that and didn't even know until he was probably like 50 years old, simple heart murmur, stuff like that.
As Sara mentioned, CHD is the number one cause of birth defects that you're born with. But what people don't always associate is that CHDs are 50 times more common than childhood cancer. And so we hear a lot about, the American childhood cancer and a lot of fundraising for that, but CHDs are more common than that. But they receive, I think, like a tenth of the funding that childhood cancer research does. So there's just not as many resources put in there. Most of the causes are unknown. Sometimes they're genetic. There's environmental. They really don't know. I've had conversations with my grandmother after Kelly was born, and she was telling me that before my dad was born, she had another baby. My dad has an older brother who died at about 10 days of age, and she said that she called him a blue baby. And then, so the more I talked to her, and she's like, well, I didn't know what it was. He was just blue. He couldn't keep any food down. And I was like, well, Grandma, he had a heart condition. He had a birth defect, and that was 1943-ish. I think my dad was born in 45, so she had three sons within like a 5-year period.
And my grandfather is actually a twin. So we haven't shared every single story, so I'm learning that right now. My grandfather, so my mom's father, was a twin, and his twin passed away at about 3 months old.
So there could be
genetic
links. Earlier this year, I attended a virtual retirement party for the surgeon that did 3 of Kelly's surgeries, and it was interesting to see how many parent-child combinations they had done surgery on. They had operated on the dad, and then later the dad's child came back with this, a heart condition, not the same one necessarily, but so I think there's definitely a genetic link. They just haven't, they don't really know. I think we kind of talked about that. 85% of the babies born with CHD now are living past the age of 18, so that is a huge improvement. To the mortality rate was much higher. Yeah. Yep. And then CHDs can have lifelong neural, developmental, and neurocognitive effects on the children. Think about, I like to say one of the effects of having a heart disease or a heart condition is low oxygenation of your blood. That blood goes to your brain, to all your organs. So if you are in utero or living significant amount of time before surgery with low oxygen levels, it can impact brain and development. And we'll talk a little bit more about that as we get further into it.
So these are a lot of the common types of heart defects.
And we're not going to go through each one.
And with these, you can also have combinations of them. So the variety, it's so funny, a lot of times I think the questions we always get are, is your baby's defect like my baby's defect? Or do they have like so-and-so? And it's like, they could have a lot of different things too.
Yeah.
So it really varies.
And we all speak our own language, heart parents. So we have support groups online and stuff. They'll say, "Oh, post your kid's defect," and it's all these acronyms. You're like, "Oh, HLHS and VSD, ASO." It starts.
COA, VAB, yeah.
I had referred one time and said that Kelly had MS, which was mitral valve stenosis, but my aunt thought that meant something, a different MS. So there's a lingo that goes with it. But this is just the most common. We stole this from the American Heart Association. I did from the American Heart Association. We're not going to go through each of those, but we'll go specifically through they share a defect, and then Kelly has additional, and he has some additional. Well, I'll talk first about Kelly, since I told her I have 7 times the experience. Having her be 14, and Elliot is 2, so I have a little extended. But she was born in 2007, full-term baby, 40 weeks. Everything seemed pretty normal. She was average size, 7 pounds 11 ounces. Passed all of her infant screening tests except for hearing. That's the one that she didn't pass, was hearing. Ended up taking her to DeVos Children's for additional hearing tests. Hindsight, I never got any results, so I thought, must be everything's fine. No, I think I didn't get the results because at kindergarten roundup, they're like, your child can't hear out of the one ear. I was like, really? So I had her tested, and then, they would explain why when she would say, Mom, and I'd say, yeah. She'd be like, where are you? She can't place direction because she can only hear out of one ear. So profound loss in her right ear. But at the hospital, I did say to the nursing staff that I didn't like the way she was breathing because this is my 3rd baby. And I was like, I don't like the way she's breathing. It seemed really labored. Her abdomen was, up, down. And they said, oh, she's fine. She's a belly breather. I was like, okay. I mean, you see babies every day, So we left. Things weren't great at home. She struggled to nurse. She was always falling asleep. It was just too much labor for her to nurse. Again, I still didn't like her breathing. So at her 2-month-old child visit, they said, do you have any concerns? And I said, yes. I still don't like the way she breathes. And she also had then fallen below her birth weight. So she just wasn't gaining any weight. So the pediatrician actually listened carefully to it and heard a heart murmur at that visit. Sent her right there on site for a chest x-ray, and we were given 2 options. DeVos Children's Hospital is via air or via ambulance. So we said ambulance, and off we went. Because I was like, I'll drive her, I've been driving her around for 2 months. They're like, no, we can't risk it. So we left there like that. I had my other 2 kids with me, so it's just, calling a grandma to come get them, and off we went. So that was not our first hospital, or first ambulance ride, but I don't think she remembers any of them, do you?
Well, I remember one because the guy let me listen to the music.
Yeah, so ambulance, you don't necessarily think, but the ambulance rides are something we're, I wouldn't say used to, but they're not. There've been a couple. So we get to DeVos Children's Hospital. This is before the big remodel because this was back in 2007. So it was kind of a darker place. Just seemed physically was darker. The lighting wasn't as good. It wasn't as bright and cheery, but it just seemed dark that day. But they did some checks, echocardiogram, and she was diagnosed with 4 different defects. 2 of them being the most concerning, and Needed repair pretty quick, like were ventricular septal defect. No, I have slides to tell you what those are. Coarctation of the aorta, which is the one that they share. And then her heart valve, the mitral and aortic valve, were stenotic, so stenosis, so they're too small. They couldn't operate very well. And a combination of those, they call it Shone's syndrome. So I don't, just is. And I hadn't heard, actually, no one referred to it as Shone's syndrome to me until she was maybe 9 or 10 years old. So I don't know if they just, as they learn more through research, they start lumping things together. Anyway, so the most common heart defect is the ventricular septal defect. So if you have ever heard of somebody saying that they have a hole in their heart, that's what this is. It's the hole in the heart. So I have a diagram, but I'll show you up here too. So it's a hole in this wall that separates these chambers. So the blood just kind of gets back and forth, and some's oxygenated, some's not, and it's not very efficient use of the oxygenated blood. So this is a diagram of a VSD. So the hole is between the two lower chambers of the heart, and the blue is the oxygenated blood going out to the body, and the red is what needs to go to the lungs yet to pick up that oxygen, but it keeps getting mixed in with the oxygenated, so she wasn't getting the amount of oxygen throughout her body as she needed to. Plus, it's hard to pump, so you've got leaking things happening. Sara will talk to you about this one.
So the coarc, that was how it was introduced to me when we were in the emergency room, a coarc. And I'm like, what is a coarc? Yeah. They just get used to acronyms and abbreviations. It's kind of like looking at your aorta and imagining it being kinked like a garden hose. So this one. It can't deliver blood the way it should. And so what they actually have to do to repair this is it's called an end-to-end resection. That's I guess the most invasive form, is literally cutting out that section that's kinked, has a tiny hole in it instead of the full aorta size, and repairing it, re-sewing together. They can also repair them as they get older with stents, going through, putting a stent in, and enlarging it. So that's one of the things with a coarc. It's constantly monitored because it can always reconstrict.
Because it's scar tissue, yeah, exactly. So that's one thing. And it's funny as you only maybe hear what you want to hear, but they don't tell you everything. And eventually they're like, oh, we're watching Kelly's coarc repair to see if, I'm like, oh, I don't remember you ever saying that might need to happen. Yeah. You just never know. So yeah, so with Kelly too, she had the same defect. It acts as almost like a dam, so we're not getting as much blood again going where it needs to go, so they have to cut it and reattach. And I didn't mention with the VSD how they repaired that, is they sewed a Gore-Tex patch in there. So she has a Gore-Tex patch. I'm like, well, we know that because my ex-husband was a hunter, so we were familiar with that material. But anyway, and I was telling my coworkers this morning in my office that when they tell you that, they're going to sew a patch, and they're like, well, the biggest danger is that when we're sewing that patch, we'll hit an electrical current in there, and it may not. Electricity might be gone from her heart. And I'm just like, awesome. Yeah. But it probably will come back. Okay, it probably will come back. So that was fine. And then Kelly also had 2 stenotic valves. At first, I heard more about the aortic valve being the problem. Her mitral valve was also stenotic, meaning it's just too small. Again, acting like a dam, not letting as much blood in or out as it should, and that affects the blood pressures in the other parts of the body, particularly in her lungs. She was suffering from pulmonary hypertension by the time she had her second surgery. But so anyway, so the first time, well, I'll talk about it here. So that was when she was 2 months old. She was diagnosed, but they didn't want to do surgery until she was 6 months old because she just wasn't strong enough to be able to survive surgery. Oh no. Sorry, Lisa. So it was a long 4 months, from 2 months to surgery. At 6 months, she was sick a lot, in and out of the hospital. One of the things that she was struggling to eat. Even a bottle was too much effort for her, so we had to do an NG tube, and then a feeding pump, which is up here, and she would sleep there overnight, or I have another picture, in another chair where she was, a little elevated. Her head was a little elevated, so the gravity would help and keep the food down. It was just low and slow. Slow feeding, so that because she was also, then if she had too much, she was reflux. It was pretty bad. But they didn't want the NG tube in at daycare, so every day we took it out and put it back in. some things you don't know that you can do or handle, but you can. So only, I was telling her last night, only one time did I make your nose bleed. And I was just kind of done that. I was like, okay, I'm done that day. But this is a picture from a hospital visit. She just was suffering from failure to thrive. It was a long, it was a long 4 months. I think there were 3 hospital stays in that 4 months to keep her going. And one more, she had me change out a couple of these pictures last night. So we made some changes. So this is another hospital stay. It's hard to tell, but her IV is actually in her scalp. It's in her head because she was so dehydrated otherwise that they couldn't find a place. That's when they take, after they've tried to put the IV in, mom's in tears, the nurses are in tears, then they just take the baby. They're like, okay, we're going to be back. And they came back and it was in her head with this little clear dog, they call it dog house over it so she can't get at it. And then some bandages. And then this is her older sister taping up her forehead for no apparent reason, but she thought that was funny. And then another hospital visit just showing the oxygen. This was October 8th. So that's less than a month from surgery, her first surgery. So this was September 29th. So there's 2 visits right there, September, October. I know there were at least one more probably in there. And that was the 19th. So we're getting much closer to the surgery date there. So first surgery, November 6th, 2007. It's still an anniversary we celebrate. We went to U of M, CS Mott Children's Hospital. That was a battle. Things you don't think about, but we had at the time Priority Health Insurance, and they were adamant that we have the surgery done at Spectrum in Grand Rapids. The cardiologist at Spectrum said, no, we're not capable here. She needs to go somewhere else. So the cardiologist actually lobbied with the insurance company and got it approved so that we could go to CS Mott for her first surgery. So they passed the BSD, they repaired the coarc, and they did just surgically dilated the valves to make them a little bigger, make the opening a little wider. And this was our shortest surgery stay, 8 days in and out. Babies recover so much faster than the older kids. They really do. They're so much more resilient. I know this picture is kind of hard to look at, but it'll come into play later. But there's little wires right here on the outside, bundled and taped. Those are called pacer wires. Those actually have probes that go into her heart, so if it had stopped beating, they could pick her up on a pacemaker immediately. So those every baby that goes through surgery did.
He didn't
have those.
No.
Because she went through, because of all the work they had to do, she had to go through the sternum to have her repairs made. And I have to say, one nice thing that they did great at U of M, they still do, is they partnered us. So that same day, there was another family that had a boy who was having surgery. So we waited together while the kids were in surgery because he had a different surgeon, and then they shared an ICU room. And so we just got to build that bond, and they do that on purpose, which I think makes the 2021 so much harder too. So she was great. So it worked. She grew. She thrived. This is less than a month post-op. Sorry, you can see that her scars healed really well. Her cheeks are filling in. They're bright. Her eyes are just brighter and healthier. She can eat. The reflux issue had gone away. She was strong enough to have a bottle. She left the hospital without any heart medication. And I didn't mention, but she was on heart medication leading up to the surgery. She was on the Lasix to keep the fluid off her lungs. She was on digoxin to help her. It was a pressor to help the heart pump a little stronger and things like that. So then we cruised. That was 2007. We cruised almost until 2012, knowing that they were keeping an eye on those valves. And it was the mitral valve that actually started to be the problem. So I was telling her last night, she doesn't really remember, but at my house we have a pole barn, and our house is maybe 50 yards away. It's not real far, but she couldn't walk from the pole barn to the house without having to stop for a break. So we could tell that things were, her energy wasn't what it should be. So this was, again, at CS Mott Children's Hospital, March 21st, 2012. I got it. This for me was some of the hardest part. Was just, you can just see on her face how hard it was, because you have to push them. When they're babies, they recover and they can't really fight back. And they don't, if they feel pain, they just cry. It's hard to know really what the babies are going through. But when they're 4, almost 5, because she was almost 5, her birthday's in May, making her get out of bed, making her go for a walk around the unit, sometimes it was really.
Well, and even seeing the young ones as,
Yeah.
you know, they're coming out and they're making them do those laps around, your heart just breaks because you know they're going through
it's hurt,
pain.
right? And it's hard to see in this picture, but there's chest tubes as well. So when she's trying to walk, you know, she's got IV poles and you've got chest tubes and you've got a lot going on there. But she just, even her older sister, she was like, I'm not dealing, like I don't want anything to do with you. We were just trying to get her to eat. This, I guess, is a good thing to point out. Her main line was in through her neck. It usually is. They suture a main line right there so they can do blood draws and infusions through that, which is nice because I think probably maybe she can tell you, but pokes at the hospital are one of the hardest. Yeah, she just stiffened. Yeah, those are still one of the things that she's a pro at now, but
I still hate them.
she still hates them. Yeah. So unfortunately, that repair was unsuccessful, and we couldn't leave the hospital. We had to stay and have another open heart surgery to replace the mitral valve. So the repair actually dilated it too much, and it was leaking, and it was kind of like non-existent. So they felt that her health was in such jeopardy that they wouldn't let us leave the hospital. We had to stay there until she could get back in for another surgery. And
I do have to appreciate the sentiment on this because I think both of us have admitted our third get away with murder and with everything, and so just here, have a whole box of chocolate.
Right.
You get what you want.
Yeah, this was sent to me from my friend, but she was like, oh, chocolate. Now she doesn't even like strawberries.
That's why.
But what's also nice is you're on, you know, at U of M during this day, they have nice community spaces and community kitchens, and so you get to know the other parents that are there. They have craft rooms for the kids to play in. She loves doing the crafts. One of the other parents lived in Lansing, so they kept bringing MSU Dairy Store ice cream. So that was nice. Like, you going home today, Chuck? Like, what flavor can you bring back? So you get a sense of community with the other heart parents. So, though 9 days later, March 30th, they replaced the mitral valve. So that was hard news to take, that she had to go through another surgery. Because of that slide where she looks sad, you know, just knowing that she has to go through that recovery again. That's, I think, the worst part of it for me. How are we doing? We can talk about this forever. I'm trying to go quickly. So that one, she made it through. Flying colors. It took a little longer because if you have mechanical heart valves, you need to be on blood thinning medication because the blood thinners will prevent scar tissue from gathering around that. The valve is carbon and steel. And she clicks. Maybe that can be your show today. You can go around and people can, like, you open your mouth and they can hear you. Where's the microphone? So actually I didn't hear her too much after when this mechanical valve went in, but now she's much, much louder with the bigger valve. So in all, we were there 21 days. I didn't come home the whole time. I stayed there. There were a couple nights I didn't stay in the room with her. Her dad stayed in, and then I went to one night we were going to do the Ronald McDonald House, but honestly the room was so small that I gave that to her dad, and I got a hotel because it was just so tiny. We were trying to do 2 people in there, so we just swapped out. But yeah, so then smiles. I think somebody said that was probably a Versed-induced smile, just a little pain relief. But then in 2012, things were great. I mean, she grew, she developed, went on vacation, everything. She doesn't like looking at her teeth on that slide. Braces since then, yes. And we were going for checkups once a year in Grand Rapids. Towards probably in about 2018 or 19, it started being every 6 months, but once a year, just checking things out. But then they decided it was time to upsize that valve because the pulmonary hypertension was starting to increase and her energy and stamina was decreasing. So, time to upgrade or upsize it, but during a global pandemic. So that was March 2020. We had planned on going on a cruise over spring break and then in April having the surgery. That was the plan. Cruise canceled, surgery instead. So it was March 26, 2020. I asked the surgeon, I said, oh my gosh, is it safe? And he said it's going to get way worse before it gets better. And he was absolutely right as far as the pandemic is concerned. But think back to that time period. It was single, everybody was by themselves. So that was a hard thing to go through. I didn't realize there was animation on that one. Sorry, excuse me. But, so on March 26, 2020, they upsized the mitral valve, and they went from a 19 millimeter to a 25 millimeter. That's a pretty big increase when you're talking about the amount of blood that can go through an opening. I will not editorialize. I will just fact. But that flood of blood hit her lungs, and her lungs, the capillaries and the nerve system through there, pulmonary system, could not handle the amount of blood that came. And about I said 2 hours, but then the more I thought about it today, it's probably about 5 hours after surgery, she coded and had to be resuscitated twice. So that kind of changes like everything in your view. But it was, I think the worst part about that is just that I was by myself, because you couldn't have, even peds couldn't have another parent with you. So her dad was there in the waiting room with me for a while, but they finally kicked him out. Like, even though we were the only two in the whole room, and you can imagine how that's the surgical waiting room in the basement of the children's hospital. It's pretty big. We were the only two there, and they still made us go. And I know they were just following the rules, but it was lonely. And then to have this happen, yeah. So a lot of thoughts go through your head, but these pictures here, she made it through. It was a long, stressful, scary night, because that happened about 7 p.m. because it was shift change, I remember. And so we got double the staff that came to the room when she coded. They really did it just like in the movies. The blue lights go, and people come running, and it's. I had witnessed it, but it wasn't my child, right? So to have it now this time be your child was just kind of very humbling. So we got her through. The first night was really rough. I've never seen an ICU nurse be so attentive. Literally sat in a stool and stared at these monitors all night, every 15 minutes on the phone with the intensivist that was on staff.
Each one of these is controlling a medicine
Yeah.
of some sort.
Yep. Every one of these pumps, yeah. So these are all different medicines that she was on. And then of course the monitor. This is the ventilator machine keeping the vent going. And my pillows are over there trying to be. You also sleep in that same room where they are. So, but he just sat all night and they just kept watching the monitors, talking, making adjustments to the medications. I'll talk about it in just a second. But one of the medications she was on is really risky for your brain. He's like, we can keep her going, but we don't know exactly what it's going to do to her cognitively if she's on it for a long time. Well, by the time morning came around, the intensivist said she turned a corner. We can start backing things off. So, but when you return to the room, because they ushered me out when she was resuscitated. I was there the first time. I was holding her hand. I did that first compression. But then I kind of was like, oh, I got to get out of the way. Like, I'm not helping anything. So I got out of the way and in the corner, and they rushed in a steel thing full of medical supplies, and they just opened it, and they were ready to open her there in the ICU room. And I actually thought they did. So when I was by myself, they got a social worker to sit with me, but they kept coming in and talking about things like ECMO. I think a lot more of us have heard of ECMO now because of COVID, honestly, and some of the treatments people have to go through. But they're like, I'm like, I know what that is. I know you're essentially saying you might have to hook her to a bypass machine that's outside. Like, you're going to pump her blood for her, right? But so in my head, I didn't know what's going on. But when I finally returned to her room, I was happy to see they didn't actually have to reopen her chest. They thought maybe fluid was building up. But anyway, I get emotional with that. I'm doing pretty well actually. So then we started taking her off those meds. She's on the ventilator still here. Communication was a big problem. She wanted to speak to me so much, but she couldn't. I couldn't understand her. And she was always thirsty, and she was hungry. So we did resort to writing, and sometimes I knew what she was writing, and sometimes I didn't know what she was saying. They had her on a pretty heavy dose of fentanyl to keep her conscious but unaware, right? So she was, one of the notes she wrote me, and I figured out later, she was trying to tell me that something she saw above her was below her, and then I finally realized she was telling me she felt she was floating. She felt like she was floating. We did finally work with the nurses, and they went to the adult side of the hospital and got a board, and the board had pictures, so she could point to me, I'm thirsty, I need suction, I need to go to the bathroom, so she could communicate better or even just say good morning or good night. So she said, we went through it last night, she said she doesn't remember that. And I said, that's probably good. That's probably
Last night you were like talking to me about the big medicine stuff, the really hard one died, and then I asked you how your day was.
Oh, yeah, so the first thing Kelly said to me, so every day at dinner time, Kelly asked everyone at the table, how was your day, Mom? How was your day, Vern? How was your day, Lindsay? The first thing she said to me that I could understand was, how was your day, Mom? And I just knew, I knew she's there. She's there. Yeah, Kelly's still there, because I didn't know when she was going to wake. I didn't know what I was going to find when she woke up. So I was like, oh, she's still there. So then we just spent, we had a pretty long visit again, because she just could not get that blood flow. Like the heart was just not happy. So what ended up happening is her cardiologist and I have a different view. He says, oh, Kelly, you had a really good outcome. I don't think that, to me it wasn't super successful. This is actually an x-ray of Kelly's heart. She has a pacemaker. So one of the side effects of the resuscitation and the bigger heart valve is she has complete heart block. So the upper chambers are firing, the lower chamber is not getting the signal because that mitral valve it was so big it pressed, the signal can't get through. So they had to use the pacer wires I had pointed out before. So those were going, and I don't think you can see it in this past picture, but there's hanging from this down here is a pacer box that they would change the pacer settings on and try different things. Every day, twice a day they were saying, okay, is it still blocked? Is it still blocked? And it is still blocked, even now. So the pacemaker, I don't know, how big is that, Kelly? It's about like that. She told me I should have put the picture up there. But it's planted under her skin right here. Yeah, about that. I don't know. About the size of, I don't know, 2-3 inches. Yeah. It was implanted there. The wires go through her arteries into her heart, and they're anchored in there, almost like metal screws, sharp. And then you can see these wire ties. Those are when they close her from surgery. She has the ties in there. But after 16 days, she finally got to go home. And it was a very stressful time, especially doing it alone. They did the night she coded, they did let my husband came and visited. He didn't stay over. And he actually tried to convince me to leave, but Mom, moms are, we're not going anywhere. He's like, you're not going to get any rest. I'm like, I don't care. I can sleep later. But she did come home on sildenafil for the pulmonary hypertension. So the sildenafil lets the capillaries expand, let them just handle more blood flow. So they had her on nitric oxide gas and then transitioned her to sildenafil, which I don't know if I should tell you what the commercial name for sildenafil is. Does anyone know? You do, don't you, Kelly? You want to tell them? Okay. Viagra. So taking her to a well-child visit, and the nurse goes, oh, this can't be right. She's not on Viagra. I'm like, actually, she is. Sildenafil is, allows blood flow. I mean, it's doing its job. It was doing its job in her lungs. So, but she's off that now. She was on that for about 6 months after. But at her last visit, he mentioned that the pulmonary hypertension has not completely corrected itself, and maybe sildenafil will be in order again, which she's just shaking her head right now, because that's a 3 times a day, pretty strict. It has an 8-hour half-life in your body, and then it's gone. So you have to kind of keep that up. But I would say, this is our new normal. Kelly's still doing marching band, going to homecoming dances. Things that she does do, though, is daily she takes those blood thinner medications, weekly blood checks. We used to have to go to the hospital and she'd actually have lab draws, but in 2020 they ordered her a home meter, so it's like a glucose type meter. So she just has we prick her finger, check her blood, and then I have an app on my phone. I send the results to the doctor's office through the phone, and her pacemaker is Bluetooth too. So every quarter we have to send a transmission. It's on my phone. We sit within a couple of feet of each other and sends a transmission to the cardiology office. There are some things that, though, she will never be able to do. Contact sports, which I don't think breaks her heart. She just had a rough week 2 weeks ago traveling with the band to Orlando. There were some roller coaster rides that they would not let her go on. Her cardiologist had given her the green light hesitantly. He said he's the only cardiologist he knows that's lost a pediatric patient to an amusement park ride. So he reluctantly gave his blessing. But I think it wasn't, there were a couple rides at Universal that have metal detectors as you get closer. Were they closer, Kelly?
I think they were right in the start of going.
Oh, so you couldn't even get in line. So Kelly can't go through metal detectors, so they asked if she could go around, and they said no, she can't go around. And they said, well, she has a pacemaker. They're like, well, then she can't ride the ride, you know.
Well,
and I understand.
They were like, we can ask someone to come up and give us permission to wand you. And then they were like, when the people came up, they were like, no, it helps your heart, you can't go.
Yeah, so things like that. And because of the blood thinning medication that's been recommended to Kelly to never have children of her own. The pregnancy and childbirth would not be something that she could do with her body. So that was a conversation. We talked about it since as early as we could, because I didn't want that to be a shock or surprise to her later. But I mentioned the neurological and neurocognitive effects. It does create challenges in education, employment, and social relationships, and not just for the patients, but also their families too. But Kelly specifically suffered from developmental delays early. She had services from Great Start, so speech, occupational, physical therapy. They went to her daycare once a week, or then we took her to special playgroups. She graduated from that program around, 3-4 years old. She didn't start walking until she was almost 2. Speech was delayed. She didn't say a lot, but she's very expressive, but just didn't say as much. And from all the time laying on her back as an infant, she has a bit of a flat skull. We tried the helmet, but we did it for like a week or 2, and I was like, I can't do it. It's too hard. She hates it. She would cry every time you put it on her. But then we discovered the hearing loss. Amazingly, the first couple years of elementary school, no one suggested a 504 plan or accommodations for her hearing, but then I think it was second or third grade, they did. Thanks to a great principal who then was the superintendent, who's now retired. If anybody knows Amy Meinhardt, she was helped with that. But then as she got a little farther along in elementary studies, we just, being my third kid, I was recognizing some of the things like difficulties at school, not being able to focus to complete a task or complete a test. She could do the front page. Farther she gets along, less and less, and sometimes just scribbles. So I had her, I was wondering, there were some learning disabilities. I had her tested and confirmed that she has ADHD, but she can't be medicated for it because of her heart. And then after the 2020 surgery, I just mentioned some of those drugs that they used to keep her alive that first night, the heart pressors and stuff, can have cognitive side effects. But so I still think I haven't said this to her a lot, but she's a little different than she was before. Like academically, I can tell. But also I had to say March 2020, then a year of homeschool, because I'm like, I'm not taking her to school. No, I'm keeping this kid home with me. So but she does have some short-term memory issues. She's not great with names of anything. She has struggles sometimes to find the right words to express things. She'll say, that thing. I'm like, oh, I need the name. But the research has confirmed that there are connections between learning and developmental issues with kids with CHD patients. And then, CHD, lastly, before Sarah's turn, because I talked a lot, is hearing. Actually, after having a conversation with you a couple years ago, and then this, and then I putting this together, I just did a quick search, and there is a link, I read that the statistic is CHD, people who suffer from CHDs are 30% more likely to also have hearing difficulties, slight or total or something. So something when the heart is developing, the ears are developing, and because they did MRI, they couldn't find anything anatomically. Yeah. So,
okay. Okay.
Sarah's turn.
Elliot, that's Elliot. He was baby number 3. No signs. He was 40 weeks. He was on his due date. He's my second baby born spontaneously on their due date. They just to the point. No signs. They diagnosed me with polyhydramnios, meaning I had too much amniotic fluid. And so probably closer to week 32, 33, they started doing weekly NSTs. And they just hook you up to the monitor. I thought it was the greatest thing ever because I got a week of uninterrupted quiet time. So once he was born, he passed all his tests. no big issues. He was 9 pounds 1 ounce. The nurse that was there in the delivery room said, "Do you have a name?" And I said, "No, not really yet. I think we do." I was pushing for Elliot. My husband was not. She goes, "Well, what's the older brother's name?" I said, "Miles." She goes, "Well, we can call him Moose. He's practically the size of one." And that saved his life. So that's why we kind of call him Moose. That's why we call him Moose. When he was born, about, after 24 hours, he was really sleepy. I thought it was great. Kid 3, he's sleepy. Jackpot. She was concerned. She wanted us in right away. Looking back, and you always do hindsight, I'm kind of mad. I wish she let me keep my appointment, because I think we would have not been in bad of shape if we didn't go to the doctor so soon, if that makes sense. And that's going to kind of come up here in a little bit. So,
sorry, what's your
no, you're fine. So, kid 3, he's great. There were technically no birth defects. They wouldn't do a circumcision when he was born, and I couldn't figure out why. And they said that he had hypospadias, and they say one defect signals multiple defects. And what that means is his urethra, well, it's not really bad. It's just a little bit below, kind of the tip of his penis instead of right at the end. And so they refused to do the circumcision right then and there, which then caused issues later on for us. It's not that big of a deal now, but we had to actually, after going through this whole thing, I bring that up to when we get admitted to the hospital, and they go, "That makes sense." So there's some sort of relationship in there as well. So one defect, multiple defects. So, and you can see his foot size, he was massive. He was always squinty faced, always eyes scrunched, and that's big sister and big brother. So he was born on October 13th. That was as wide as his eyes ever got those first 10 days of his life. Day 9, end of day 9, about 5 p.m., he was eating about 3 ounces every couple hours. Now he was going about an ounce and a half. That was about 6 p.m., 9 p.m., half ounce. From 6 p.m. to 6 a.m., in those 12 hours, I only got 3 ounces down him of breast milk. And so he was extremely dehydrated. I called the nurse on call, and I'm like, "Hey, something's wrong." And she's like, "Well, what are symptoms?" He would lay on me. He'd kind of feel sweaty, but cold. Cover him up, and he'd go, That morning, we took him in. He had blue feet. His feet he was just kind of limp and just not a normal newborn. And we take him to the ER. The next slide's going to be really rough. We take him to the ER, and this guy saved his life. That guy is Ben Fleet. He's probably, and I praise his name every day, because he used to be on the cardiac intensive care unit for pediatrics at DeVos as one of their head nurses. And he started working at Greenville because it was closer to home. And I bring him in, the nurses are like, "Oh, what's wrong? Labor breathing," and he kind of has that chest is, kind of sinking in. And he's like, "Oh, okay." Takes him in, he starts flailing around with a paper towel, to put on the little balance scale, weight, whatever, chemistry teacher. And he's like, "Oh, this little guy needs a doctor," and he just runs off. And this is October 23rd. This is the chemist holiday. This is the mole day. And it is forever Elliot's day. And he is filled with fluids right here. He looks like he's the size of a 3-month-old. His weight went from 9 pounds 1 ounce. I think by the time we got him in there, he lost a full pound in those 10 days. But his size saved him. And his coarct was cinching down all the blood, so he couldn't get it down to the rest of his body. So his body was breaking down every single sugar. And as it broke down every single sugar, to get any form of oxygen into his blood, he was filling up with lactic acid. And so he was in heart failure, and he was toxic. If we waited any longer, he would not be here today. So that unhealed stump, because he wasn't getting any oxygen, saved his life, because that was the only place they could put an IV in. So I've never seen an ER room fill up so fast. You go to the ER, it's supposed to be a therapeutic visit. They just ran off with my baby.
Yeah, they're supposed to, you go there. I would take her for everything, right? I remember calling the cardiologist. She has a fever, and he'd be like, "A fever is not going to cut it." But yeah, it's just.
And so they scheduled surgery for the following day, and when they did, we got to take the NICU transport team, and I said, because I kept hearing, are we going to do the bus downtown or AeroMed? And then all of a sudden the social worker comes and I'm just a mess and I want to be left alone, and then the chaplain comes and wants to say a prayer for baby Elliot. And it just hits. And we get into the transport team bus and I said, how are we going back? And they said, we're just going cool and calm. And I said, that's good, right? And they said, no lights and sirens, that's good. He's stable. So they stabilized him. The NICU transport team bus stabilized him. This is a cross section of an aorta with a coarc. You can see there's a tiny little hole right there. And then one of the things with a coarctation is every child with a coarc has a bicuspid aortic valve. Not every child or individual with a bicuspid aortic valve, only 2 flaps instead of 3, has a coarc, but if you have a coarc, you have the BAV as well. So, and he also has, they thought when in utero, they think that, or not, the top 2 chambers, there's a slight hole, and then as they grow, it closes. And so they don't know if his ASD in between the top 2 atria, the top 2 chambers, the hole in there is just, it didn't close or it truly was just a malformation. So, this was the day he came back from surgery. Lisa drove all the way down there to spend it with Ryan and I. And walking in, it scared the crap out of me because you see all these cords, you would just see them laying there, and it's hard. They call these the Christmas trees because they're lit up all the time. And they're taking the drainage tube out here, which is great. Now, one of the things that's different from Kelly's is Moose's, he got to go, you can see his surgical site is on his side. And so they let me hold him, and one of the nurses came in, she was like, and I was like, no, they told me I could hold him because he didn't have the thoracotomy. And you can already see the following day how much more open his eyes were. And I have a video when he opens his eyes and you can just hear him, he's like, oh, it's just that. Yeah, so constant monitoring and his moose. So being the size that he was, it saved him because he was in really bad shape. And I thought he was just a sleepy baby.
Yeah.
So, now, this is a little screenshot. I would keep track of his blood pressure medicines in terms of how his blood pressure was about an hour after he took that medicine, because he has to take, right now he's up at about 1.7 milligrams of captopril 2 times a day. The circumcision that they denied us, we had to get a special appointment, which meant a special cardiac anesthetist. And so anytime they go under, they have to have special anesthetist for them. This is an echo, and then this doctor right here, she was the one that met us in the NICU, and she said, nope, we're going to get you out of NICU and take you straight up to the ICU altogether, the pediatric ICU. And she claimed him. She met us in surgery the following day on the waiting room, and she's like, can I have him on my caseload? I'm like, absolutely. You saw us at our worst. So, yeah. And she's fine as long as I, keep monitoring his blood pressure. If it gets too high, we got to give him a little bit of a different dose, maybe just a 1 more milligram, or not 0.1 milligrams, not a full milligram. So, the fellow, when we were in there, said the hardest thing you'll ever have to do is let him be a normal boy. And I think that's really hard because we have trauma from that, and it's hard to let that go. Now, this little guy, one of the things that I'm okay talking about it because I think there was so much shame and stigma of defects. What did you as a mom do wrong? And you have to really realize sometimes you just get a crappy spin of the genetic wheel. And this little guy, he had GTA, TGA, transverse of the great arteries. Everything was swapped. So, long story short, he's a cousin of one of my bridesmaids, and we met each other through Elliot's story. So it's kind of cool. You can see he's just a regular boy being a boy. So.